Good evening. Good evening from UK and anywhere you are. If you have night or evening in your country, welcome to our MRCP RFA group. And today we are doing a very important topic called atrial fibrillation. And this is very important topic as we all know. We always go through the MCQs with regards to it. And if we don't understand atrial fibrillation, we will not know how to go for the pharmacotherapy. Welcome all again, and anyone who is joining, please mute yourself so everyone can listen clearly. So in this webinar today, we will discuss what is atrial fibrillation, and then we will know that how we are going to manage the cases of atrial fibrillation, because as we all know that atrial fibrillation is associated with the risk of stroke. So first of all, atrial fibrillation. So atrial fibrillation is an asynchronized, fast, irregular movement of the upper chamber of the heart, which are called atria. And why we have this abnormal asynchronized movement? So the idea behind is that it is because heart electrical activity is generated by the pacemaker, which is not the natural pacemaker, which is our SA node. So due to which the heart chambers, rather than having proper contractions due to inappropriate electrical activity, they get fibrillating. And as we all know that the blood flow in the heart, it goes from our atria to the left ventricle. So if we will not have a good contraction into the upper chamber of the heart, so blood is not pushed appropriately into the left ventricle to produce a good stroke volume. So as the blood stay into the atria, then it causes the dilatation of the atria. And if it stays more into the upper chamber of the heart, it makes the clots in the chamber. And whenever we get the faster heart rate, it increases the risk of stroke. So this is the mechanism and the, you can say, definition of atrial fibrillation, which causes and increases the risk of stroke. And all the pharmacotherapy depends on removing these risk factors. Then atrial fibrillation is classified into the stages. And these stages, they are also classified according to the risk factors, their duration, and the risk factor for the strokes. So the first stage of the atrial fibrillation, it is associated with the risk factors, which include obesity, lack of fitness, hypertension, sleep apnea, alcohol, and diabetes. As we all know, if I go more in detail about these things, sleep apnea, as we all know, it is associated with arrhythmias. Alcohol, as we all know, it is also a risk factor of developing lone AF, which also we treat it as a rhythm management, because as we know that if we have the precipitant and which is of acute onset, so in those cases we treat the patient with rhythm control. With these risk factors, also we know the anxiety, thyrotoxicosis, electrolyte abnormalities. So these are other risk factors which can cause atrial fibrillation. Then we have a stage 2 atrial fibrillation, which is called pre-AF, and this is associated with the, you can say, identification of developing heart failure, or it means that the patient is not diagnosed as atrial fibrillation, but he has a tendency to develop atrial fibrillation, or the atrial fibrillation has been missed in the past that could have caused the atrial enlargement. As we said, if the conduction is not going from the SA node and the heart is contracting, the upper chambers are contracting irregularly, asynchronously, they increase the pressure in the atria. Atrial flutter, this is, I would explain to atrial flutter. This is also with regards to the management. We always say it is similar to the atrial fibrillation, but in case of atrial flutter, actually atria contract by their own without generating the action potential, which can depolarize the ventricle. So in that case, that's why in the ECG, we find sawtooth appearance. And again, sometime as the patient who comes again and again with arrhythmias, and as we all know, whenever the patients come in the hospital and we have a suspicion of any arrhythmias, we go for the ECGs, sometime for 24-hour heart monitoring. So the patient who have the tendency of developing atrial fibrillation might be on those monitoring. They will have the ectopics, atrial ectopics, which means that in the future they might end up in having atrial fibrillation, as we said that this is because of the abnormal foci of activation or abnormal pacemaker in the heart other than the SA node, which then present as atrial fibrillation. And as I said, the other stages of atrial fibrillation, they are associated with the duration. So this is stage 3. In the past, hello? Anyone have any questions? So in the past, we used to say them like paroxysmal AF, persistent AF, long-standing AF. We were not having those stages which I did, stage 1 and 2. We are having this paroxysmal AF according to the duration. So this is a atrial fibrillation which resolves itself within 7 days of duration. And if it is more than 7 days, we have the episodes of atrial fibrillation. Then we call them as persistent atrial fibrillation. And if the atrial fibrillation episodes, they persist for more than 12 months, like even either we have started the treatment, and even though they are coming like this, we can say then it is permanent atrial fibrillation. So if I go further with regards to the staging and how we will go for the management of these things. So if I explain that, as I told, that in atrial fibrillation, that our heart chambers, upper heart chambers, they get asynchronous contraction, which are not the proper contraction, which can push the blood flow to the ventricle. So in that way, the blood stays in those chamber and they can dilate it. And that's why in chronic atrial fibrillation, when we request an echo for the patient, we have the dilated heart chamber. And as I said earlier, that in those conditions where the blood stays for longer time, there's a tendency of clot formation. So that's why in all the condition where atrial fibrillation persists for longer duration, anticoagulation is the choice. And again, explaining more, in the past, the decision about the anticoagulation was dependent on this duration, but now we have some, you can say, monitoring or tools due to which we stratify the risk factor and then we decide, as I told, the management is based either on the rate control or to reduce the risk of stroke by thinning the blood. And then stage 3D, as I said, it is associated if the atrial fibrillation, and we have corrected it via surgical intervention, ablations. It means that we have rectified by our electrophysiologists. They have removed that or they ablate that abnormal foci, which is acting as a pacemaker. Stage 4, we say, is a permanent atrial fibrillation, which is indefinite. And in that case, we say that this atrial fibrillation. Hello, any questions?
এটা কি খালি ইয়ে নিয়ে করে মানে গাইনি
Sorry?
নিয়ে?
Hello?
I want to know.
This is MRCP. This is MRCP group. But as well as it is useful for MRCOG. So you guys can also, if you want, if you are interested, you can just listen to it. Hello. So for the assessment, according, as I said, for the management of atrial fibrillation, we have always stratified according to the risk factors of the strokes, and on the basis of it, we decide about the anticoagulation. And also, first thing, always conservative. We have to reduce the risk, which can increase the chances of atrial fibrillation. As we said, the risk factor, we have to reduce the weight, we have to do regular exercises. If we are hypertensive, we should have proper management of the blood pressure. We have to reduce our alcohol intake, which also another risk of causing arrhythmias. And if you are diabetics, our control should be appropriate. Symptom management, as I said, if the patients, they are coming again and again with irregular heart rate, with the fast ventricular rate, we have to treat them and we have to make the decision according to the duration or prevalence of their atrial fibrillation, that whether they will be for rhythm control or rate control. As I said, so these are the criteria for making a decision about anticoagulation of the patient on the risk of stroke. So the most popular or commonly used criteria, it is useful and it is used in all the specialties wherever you are, either you are working in gynae, medicine, surgery, you always need to know. It is always an important topic in all the specialties, that you should know when, if the patients are coming to us with atrial fibrillation, how to manage them in gynae patients as well as in medical patients. So these are according to the, you can say, diseases, age, history of previous strokes, and according to that, if we have a score more than 2, then it means that these all patients, they need anticoagulation. And if the score, Chadwick score is 1, then we have to decide according to their risk of bleeding or their risk of stroke. And always for the ease, the people who are working in NHS, they always know whenever we are starting the treatment or making the decision of starting anticoagulation or rate control, always we have to make risk versus best risk versus benefit decision by seeing them. This is one of the stroke risk and has blood score, and as well as now we are using the orbit score, which is also tell us about the risk of bleeding. So even if you guys are from gynae, I will let you know sometime you might be asked the questions like if the risk and benefit, like risk of stroke and the bleeding are similar. I'm not sure if you guys are asked about those questions. So the answer should be the clinical decision about the anticoagulation of rate control of the patient. Any questions you guys have? If you are in gynae, I'm happy to answer you guys what happens, as I can understand that you guys are especially having the cases in which you have atrial fibrillation, which is associated with the mitral stenosis. And as we all know that in the gynae patient, always you guys have the patient who are having volume overload condition, and as we all know that also volume overload is associated with the condition which can worse their condition, make them in heart failure. And as well as we all know that atrial fibrillation associated with mitral stenosis, especially if you guys in gynae, so you have to make decision. Also there are the risk factor of using warfarin and all other enoxaparin or heparin, and it depends again on the risk versus benefit. So we will try to arrange another these topics related to the anticoagulation in the gynae patients if you guys are interested. So if with regards to the DOAC, these are the medication now. In the past, always for anticoagulation, we used warfarin, but now we have DOAC. They are also known as novel and novel oral anticoagulation. And benefit of them it is that they are easy to use. They just act on the factor 10. You don't need to monitor INR, which we needed in case of warfarin. And also they are having less risk of bleeding. But even though we have certain condition in which we have to anticoagulate the patient with the warfarin, and as we all know that if the patient who are having in the past with all the structural heart disease, all the valvular disease, it was recommended that warfarin is the anticoagulation of the choice. But now, as I said, that atrial fibrillation is associated with the asynchronized uh, fast activity or fast fibrillation of the atria. And if we have the stenosis of the mitral valve, so then it increases more risk of developing thrombus, more stasis of the blood in the atria. So in those conditions, we use warfarin as well as in the prosthetic. With regards to the DOAC, also we have to take care about the creatinine clearance. So if the patient's creatinine clearance is less than 15, then or they are on dialysis, then we can consider apixaban. But again, even this is not a very good choice. Also, we can use warfarin as well. But in those circumstances, as I said, in the condition in which we have the risk of stroke and risk of bleeding, if they are both of them, they are balanced, then we have to decide, you have to make a clinical decision according to the risk of putting them either on anticoagulation or leave them with the risk of stroke. So more about anticoagulation. As I said, that Chadwell's is most commonly used system. There are other system as well which we use, but usually in our case we use Chadwell's and Hasbled score for comparing the risk of bleeding and stroke. We have this Atrial score. It is the score which is for the risk of bleeding for the patient on warfarin. And then we have Garfield score. This is also used to stratify the stroke risk, but most commonly new scores which we are using, they are Hasbled score and Chadwell's score. In some trust, still we are using the orbit for hemorrhage, but it's at the moment it's not prevalent usually. And keep in your head that whenever we are making the decision of stopping the hello dear doctor, as we said earlier regarding the anticoagulation in atrial fibrillation with regards to the strokes and according to the Chadwell's criteria. So now come to the rate control in this patient. As we said, in atrial fibrillation, we have to control the rate of the heart and as well as to thin out the blood to reduce the chances of stroke. So with regards to the rate control medication, so first line medication which we normally use, it's a beta blocker which reduces the heart rate. And as we all know that because of the irregular, as we said, irregular, fast, asynchronized heart contraction of the atria of the heart, which increases the risk of dislodge of clot. So these are the medication. First of all, we use beta blocker or non-dihydropyridine calcium channel blockers. And non-dihydropyridine calcium channel blockers includes verapamil and diltiazem. And why we use the non-dihydropyridine calcium channel blockers? In the condition where we cannot give the beta blockers like asthma. And as we know, both of these medication, either they are beta blocker or non-dihydropyridine calcium channel blockers. They are both negative iono and chronotropic. It means that they reduce the force of contraction and the heart rates. So that's why we avoid giving beta blocker in cases of decompensated heart failure, especially in acute heart failure. And with regards to the non-dihydropyridine calcium channel blocker, as I said, they are with the beta blocker, they can be used in acute and long-term rate control of the heart to reduce the risk of stroke by controlling the rate of contraction, which is abnormal, which is rather than sending the blood from atria to ventricle, but it increases the risk of dislodge of clots from the atria to the systemic circulation. So with regards to the calcium channel blocker, they are also contraindicated and we should avoid giving them when the patient is having ventricular systolic dysfunction and decompensated heart failure. So what we should do in those conditions when we have decompensated heart failure, where we should avoid the medication which are negatively inotropic and chronotropic. In those conditions, we have to choose the medication which is itself having a positive effect on the heart contraction, which we say has the digitalization effect, which is digoxin, which especially we use to control the rate in the acute setting. And later on, when the heart failure is resolved, we can continue them with the addition to control more optimizing of the heart rate with calcium channel blocker, which we said known dihydropyridine calcium channel blockers, to which we say them as cardioselective calcium channel blocker. So with having the similar properties like beta blocker, by working into the AV conduction, they also reduce the heart rate. And with regards to the digoxin, if we are giving digoxin for long term, because it can cause also toxicity, it also has got low therapeutic index. So we always need to check the levels and it should be less than 1.2. And as we know that digoxin work on hydrogen potassium ATP pump, so its toxicity is increased in case of hypokalemia, and also we have to adjust the dose of digoxin in case of renal impairment. With these medication, also we can use the medication like amidrone. If the other medication, as I said, if there is any contraindication where we have to avoid. In the past, the amidrone was used for the rhythm control in the case of atrial fibrillation, and but it also can be used to control the heart rate, especially when other medication we cannot give, but we need to control the heart rate. In that case, for short term, we can use amidrone, and as well as we also know that atrial fibrillation is also precipitated with the electrolyte abnormalities, as I mentioned earlier, in stage 1 with, with the causes which include the electrolyte abnormalities like hypokalemia, hypomagnesemia. So always try to find out whenever we have the blood results, we have to give them an IV magnesium. We can give this medication. In the case of atrial fibrillation, it also helps when the electrolyte abnormalities are corrected. It's also helping controlling the heart rate, especially the patient who are coming with the fast ventricular rate. Then with regards to the anticoagulation, as we earlier says, that we have to decide about the anticoagulation according to the Chadwick score, but there are certain conditions when we know that if the patients are young and we know the patients are coming with the atrial fibrillation acutely, which is due to the acute precipitant like electrolyte abnormalities, they are of young age, and the duration of the atrial fibrillation, it is less than 48 hours, then it's better to bring them in controlling their rhythm by the cardioversion. And we have the option in acute setting, if they are coming in the chemical cardioversion, we can use amiodarone and other antiarrhythmic agent. But if they come in more than 48 hours and we have confirmed that atrial fibrillation is not chronic by doing the echocardiogram, and as we know, in the chronic atrial fibrillation, left atrium is dilated, and there's an indication, which I said, that they should be anticoagulated, but the duration of their presentation is more than 48 hours. So always we need to anticoagulate them, which is according to the guidelines that we have to anticoagulate them for more than 3 weeks before the cardioversion and 4 weeks after the cardioversion. And as I said, we have to do an echocardiogram, which can tell us about with the size of left atrium is the atrial fibrillation is acute or chronic, and as well as also it can tell us if we have already a thrombus setting into the atria, which is a risk factor of causing and dislodging of the clot, and which can lead to stroke because of the dislodge of thrombus. As I said, that with regards to the rhythm control, it can be done in which we say chemical cardioversion, which is with the medication, and the medication which we know they are the medication which are and used as antiarrhythmic medication. They use and they worked by working onto the sodium channel, which work for the depolarization of the cardiac tissues. But these medications, which include flecainide, propafenoid, abitolite, procainamide, but in the situation like LV dysfunction or the patient is having history of ischemic heart disease in the past, then these medications are contraindicated. And always remember, these are the medication which most of the time has been asked in the MRCP exam with regards to the, we know that they can be used as a chemical cardioversion, but you have to remember these name, this medication, they are contraindicated when the patient is having uh, in the history of ischemic heart disease, LV dysfunction. In that case, we should avoid this medication for the chemical cardioversion, or we say rhythm control. And with regards to the acute setting, if we are thinking of cardioversion, then obviously we have always the patient is shock. Answer is shock. If the patient is in shock and we have to cardiovert the patient, we don't know the previous history of the patient of atrial fibrillation, and the patient is young, and we have most likely indication is or the presentation is acute, then we can cardiovert them. At that time, we know the condition is life threatening, and then later on, always after the acute event, we have to decide about rhythm and rate control according to the Chadwick score. More about the rhythm and rate control, as I said, that those medication which are not appropriate structural heart disease, LV dysfunction, and myocardial infarction. So, as well as with the amidrone, we can use sotalol, but with regards to the sotalol, because it's also act like amidrone on the repolarization phase and acting onto the potassium channel. So this medication is contraindication in the patient who are having QT prolongation, hypokalemia, hypomagnesemia, or bradycardia, because these are all the conditions which are which also can lead to QT prolongation if we are giving them sotalol. So they increase the risk of arrhythmia and leading to the life-threatening arrhythmia, which can lead to ventricular tachycardia and later on ventricular fibrillation. As we all know, now most of the time we have to decide about rate and rhythm control according to the Chadwick score. If the Chadwick score, as we said, if it is more than 2, always we have to go for the rate control with anticoagulation. But in certain condition, if it is needed, there's not much difference now. If we are controlling the rate, we are thinning out the blood. There are less risk of having stroke and having the symptoms. But for the young patient, we know if they are having isolated atrial fibrillation, which is associated with alcohol intake, and we know that maybe it's difficult for them to continue with the blood thinner medication, which obviously they would not like to have. So in those conditions, we can consider. And then if we talk about the difference in the mortality, there's no mortality difference. Okay, but as we said, if we say if we start them, if we control the rhythm, it can just prevent them of progression, complication related to that. But obviously, if we are controlling the heart rate, giving them blood thinner, it's less likely to go into the complication of the atrial fibrillation, which can be in form of atrial dilatation and then pressure onto the pulmonary vasculature. And as I said, rate control is always, and it is generally, it is quite useful for all the patient. And so if I say the benefit, they are least, but obviously the guidelines say they reduce the hospitalization, stroke, and mortality. And these are the some indication in which we think that if we go for the rhythm control, so they are the few condition if the patient age is younger, and in the past we have proper guidelines, proper demarcation. If less than 55, presenting in less than 48 hours, low atrial fibrillation. So these were the indication. But now, due to the Chad-Basket score and Hasbel-Bled score, we always need to do those score before making the decision of rate versus rhythm control in management of atrial fibrillation. So if the patient are of young age, short AF history, high symptom burden, difficulty in achieving rate control, smaller left atrium, and more LV dysfunction or AV regurgitation. So these are the indication in which we can go for rhythm control. Thank you very much for attending our session of atrial fibrillation. Thank you very much from MRCP Mentor and RFA. we will come soon for the next webinar, as well as we are having our premium group which you can join, and in which we have pools of more than 10,000 MCQs. We have uh, notes, exam focus important points, and as well as we have the live sessions which are recorded, and also we keep recording them, or as well as I take the live sessions with you doctors. And in the end of before the January examination, we are going to start a fast track um, preparation for the MCQs, and in those course we will be doing the MCQs which are from the past papers. There are more than 3,000, 3 to 4,000 MCQs, and I will go through with all the MCQs, in which I will explain all the answers and explanation of the question. If you guys are interested, please contact RFA via our Facebook group, WhatsApp group, Instagram group, wherever you have access. Join us to make sure your success. Thank you again. Goodbye.